is recorded. It will be available on YouTube, and we'll also be sending the slides to everyone who's either attended or not attended. So as I said, this update is a general update on CPR and choking for paediatric first aid, so anyone looking after babies and children. And I wanted to just explain very briefly how the guidelines work. So guidelines for CPR and choking and all sorts of elements of first aid are set internationally. So there are a group of organisations that come together, they carry out research over a 5-year cycle. They look at all the evidence, they're informed by subject experts, healthcare professionals, families, real life experiences, for example, of people having a cardiac arrest. And then they look at what works best and they come up with a set of guidelines. They don't generally change hugely. So in the last 10 years, there haven't been very big changes. The changes that came out this October are probably the biggest changes that we've seen in 10 or 15 years, Amy, for
Yeah,
pediatric
yeah, definitely.
aid. Yeah. Um, and the purpose is to ensure that anyone delivering pediatric CPR or any kind of first aid is using the gold standard treatment. Um, but I think it's really important that I emphasize that they are generally small changes. If you use the old method that you were taught in your last course, it's fine. And I don't want people to worry that I haven't got another first aid course for 2.5 years. What if I do what I was taught on my last course? It's absolutely fine. Amy, if you can go on to the next slide, please. Thank you. So some of you will have done your first aid very recently. Some of you will be due to update. If you update with Safe and Sound, so some of you work with us and lots of you don't. And if you want to do your first aid training through us, obviously you can. We will be teaching the updated guidelines from now, we started at the beginning of January. But you might find that when you attend your next course, if it's in the next few months, that your training company won't be teaching the updated guidelines. And that's because there's a 12-month period in which time organizations can update all of their material. So all their PowerPoints, all their lesson plans, everything else. So please don't worry if your training provider teaches you something differently. You can certainly say that you've been on an update and you were told this, but it doesn't mean that what they're telling you isn't correct. Any certificate that you've got currently for paediatric first aid is still valid. It's still valid until it expires, regardless of what you were taught. You do not, under the EYFS guidelines, do not have to retake your training because there's been a change in guidelines, but you should be regularly updating your knowledge and skills, ideally annually, especially where guidance has changed. And that is part of the EYFS statutory framework guidance. So I think now I'm going to hand over to Amy Dobson. Lots of you do know Amy. Amy is a very, very experienced pediatric A&E nurse. She's also a university professor of pediatric health. She hates me blowing her trumpet, but I love doing it because she's worked so hard and she does such amazing work. But we're in good hands tonight. So, Amy, I'm going to hand over to you, and then we'll come back at the end, and I'll go through the information about the de-choking devices that I know is a hot topic.
Lovely, thank you. She always picks me up and gets it slightly wrong and gives me even more qualifications every time. So, Tina, I'm going to just ask you to jump into the chat because there are a couple of questions, but the bit I would really emphasise again to everyone, if you have got a friend or a colleague that's trying to join the call and they're struggling because of the number, just do contact them and apologise, but tell them that this is being recorded and it will be available, so they're not going to miss out on it.
Okay.
But I think it is important that we move on.
So,
Right,
Amy,
Tina?
Amy, would you mind me just saying that, can you please use the Q&A if possible to ask your questions, and we will answer questions at the end so that Amy can get through everything. So use the Q&A rather than the chat if you can, please. Thank you.
Lovely. And as we said before, we will do our best to answer all the questions. But again, if there's a question that's not answered, then send it in to us, contact us directly, and we will do our best to answer it. Some of the questions, when we get into the very complicated, but what if and what about, some, not everything has an exact science answer, but we will definitely do our very best to answer them. So I think just before I do start going through the changes, this is just really to emphasise, as Tina's already said, that no one on the call today hopefully is looking at this for the first time. You've all done a paediatric first aid course at some point in your life. Probably many of you have done lots and lots and lots of them. And this is really just about highlighting the things that have changed. And there's not a huge amount, so do not worry, but there is a couple of things, particularly around technique, that have changed. To just sort of emphasize some of that to you, and really just in the hope that should you remember some of these things, and definitely if there's two of you that have been on different courses, that you understand maybe why a friend who goes on a course in 2 or 3 months time gets told something different to you, so you'll understand that actually there is a reason why it's slightly different to what I was told, and just to help your confidence. It definitely isn't about stressing people out. If you only remember what you've been doing for the last 10 years and you do your very best effort, then that is still fabulous. Okay, so again, don't overthink. But when we're thinking, and we're only going to think about the changes for children in this course, so for infants and children, so up until the age of 18, we're not looking at adults at all. But part of the focus of the change, it's always been there for children, but it's come out a little bit more, a little greater emphasis. I mean, it's really focusing on the fact that we know, and we've always known, that adults primarily, not only, but primarily collapse suddenly, and definitely have a cardiac arrest due to a cardiac, so a heart focus problem. Whereas children very rarely will collapse suddenly from a heart-related problem. They are much more likely to collapse suddenly from a breathing or airway problem. However, the other thing that's really, and the one thing that has come out much more in these current guidance, I think we've been doing for a while, and this is a good point for us to say that if you haven't come across Safe and Sound before, and if this is one of the first webinars you've attended, we actually do a number of them. I've done a number last year, and I'll be doing a number this year as well, that really look at some of those unwell children type of situations. But one of the biggest emphasis of this new current guideline for babies especially, but for young children, is about actually emphasising that the best way to prevent and manage cardiac arrest in children is to spot it beforehand. Yes, children do become unwell quite quickly. Yes, they deteriorate quite quickly, but actually they don't have the sudden, or very rarely have the sudden, cardiac arrest that happens with cardiac related problems. They are much more likely to be giving you some clues. So we're going to think about some of those clues. Again, this is just a little whistle stop. If you really want to know more about this sort of stuff, please do join one of our next webinars where I'll be breaking this down over the whole hour and really just focusing on that spotting the sick child. So, but there's 3 B's. Probably lots of you have come across this before, lots of acronyms really in generally in first aid, but 3 B's to help you think about that child who's giving you signs that they are seriously unwell and therefore have the potential to collapse, and hopefully will enable you to contact someone and get help quicker, to think, actually, I think that this child's really, really quite unwell. So behaviour is your first one, behaviour and appearance. Bright alert children do not generally, there will always be exceptions to the rule, but bright alert children are not as likely to collapse. So we're looking for children whose behaviour changes in some way. Are they more irritable than normal? Are they crying inconsolably? Are they acting in a different way? Are they not wanting to eat and drink or play? Are they much more lethargic, or are they floppy, agitated or confused? But as I said, we go through those far more, but this is coming out a little bit more in the emphasis with paediatric basic life support teaching. Our next B is thinking about breathing. So children who are about to collapse and who have a problem with their airway or their respiratory breathing system, so A or B in our doctor's ABC, they will give you some clues, whether that clue is in abnormal sound. So there might be an upper airway sound, something called a stridor, which is as you breathe in, or a wheezing sound. But actually far more likely, especially in your infants, is how much effort is that child putting in to breathe? that becomes very, very tiring very quickly. And the cause of collapse, and definitely the common cause of respiratory arrest in a very young child, is a child who's got a breathing difficulty, who hasn't really been recognised enough and is working incredibly hard to get oxygen into their body. And either they give up because they're exhausted, or they give up because their oxygen level is not as high. And then the last one is around colour. So the third B, body colour. So behaviour, breathing, body colour. Is there some clue there that actually this child is looking very white, is looking very ashen? You'd already recognised that they were unwell. So I'm again thinking about those of you that are in a childcare environment, as most of you are here because you work with children. So you've already recognised this child is sick. You've already maybe called a parent to come and collect them. But actually, is there something about these three Bs that says to you, I need to call an ambulance for this child. I can't wait until the parent arrives. So that might be around their pallor. Are they paler than normal? Are they looking sort of ashen, a little bit waxy, so we lose that bright sparkle to our face? Or is there something that suggests there might be a little more of a mottled look? So that's that sort of marbling look. Or a blue tinge. Or if the child has darker skin tone, actually you may well be able to see that on the palms of the hands or the lips. But as I said, we're not focusing too much on that. We're focusing on the changes in the resuscitation. But if you want to know more, join us on another webinar. So one of the first things to change this year, and probably for those of you who have been around a long time, you may remember that this was way back when what we were taught to do. So one of the main things that's changed is in the compression to ventilation ratio. So for the last, I can't remember exactly how many, but I think at least well over 5, probably 10 years, whether the person you're resuscitating as a non-medical resuscitator, so for non-medical people, we have done the ratio of 30-2, whether we're doing an infant, a child, an adolescent, or an adult, it's been 30-2. For people who have been trained in paediatric first aid, so that means if you have on your course practiced and used as a key part of the course paediatric size mannequins, then the Resuscitation Council changes are that we're moving back to a 15-2 ratio. Just to give you some very brief rationale for that. Again, this is focusing on, is the primary cause of collapse respiratory or is it cardiac? Because children are respiratory, it's about getting that oxygen, getting those breaths into the child more regularly and as quickly as possible. So nothing has changed at the first bit. So if you remember your doctor's ABC, you looked for danger, you checked for a response, you then opened the airway. I'm not going into it in key detail, this is very brief. And then you check to see if the child was breathing. And in all children and infants, so everyone up to the age of 18, we start with 5 rescue breaths. That hasn't changed. That was exactly the same as before. But now we will do 15 compressions instead of 30 compressions. And then we will do 2 more breaths and 15, 2 more breaths and 15. And that's the pattern and the compression to ventilation ratio. So that's our first big change. We've moved from 30-2 to 15-2 in children and babies, staying the same in adults. The other thing that hasn't really changed, I would say this is sort of the same, but it's just been made a little bit more clearer. When we're talking about the depth, you probably heard before that when you're doing your compressions, and we've got a video coming up because I realize it's very hard to see with my hands on the screen, you're aiming to depress the chest cavity to 1/3 of its depth, which is always quite hard when you think about that because it's a large depth. So in infants and children, it's 1/3 of their depth. That's taking, again, the age ranges have come in slightly to help us with mechanics. So up into the age of 12, we're aiming for 1/3 of the depth. But when we move to 13-18 and into adulthood, generally the rationale has always been 1/3 to half of the depth. So they're giving you a little bit more of a range here and talking about 5 to 6 centimeters. What I would because I mean, you're not going to be able to measure, and can you really tell? What you're trying to think about in your head is it's a little bit further than a third, because we've got a much stronger and more robust round rib cage. But we don't want to really go more than about, we definitely don't want to go as far as half, so about 5 to 6 centimeters. So I'm not going to show this video just because of timing. We've got the infant one coming up, but just to remind you, so for a child, so from 1 year old to 18, 5 rescue breaths first. In fact, actually, I might as well just quickly play it and then talk you through it. 5 rescue breaths, and this one you can quite clearly see the chest rising, so it's much easier when you're on there. 3, 4, 5 breaths. And then we're going to move to one hand, depending on the size of the child. So between that 1 to 12 age range, you're going to move to 2 hands at the point where you cannot effectively depress a third. 2 breaths now. I didn't count her, but there'll be 15. All right. And at the point where you're not effective, then you can group both hands together as you do with an adult, link them and move and achieve your deeper compressions that way. The other thing that has changed, and again, some of you may have been shown this before if you were struggling, if you've got problems with your fingers, it may well have been a technique that you have been shown in the past, because it has been something that's always been used medically. But the current evidence is suggesting that it might be slightly more effective if we move from the 2 fingers. So again, if you just imagine for a moment, I'm sure most of you have been taught with an infant, so we're under 1 year, to do your chest compressions using 2 fingers pushing in a downward movement. Again, I've got a video to demonstrate this a bit better. However, there's always been 2 techniques. The second technique is this one shown on the screen. It's called the encircling technique. So your hands are circled around the back of the baby and your thumbs are pushing centrally over their sternum on the chest. And for many of us, our thumbs are stronger and we can be more effective, especially if we have to do this for any period of time. The other thing that is quite helpful with this is it takes you out of the way a little bit. So if there is 2 people resuscitating, it gives that second person a little bit of room. Again, we'll show you it a little bit better in a second. So here is the video. So the baby is still going to start with 5 rescue breaths. I think it's quite hard on this video. You can just about see, it depends on your light, but you definitely need to be looking and making sure that chest is rising, whether you can feel it or whether you can see it out the corner of your eye. 5 rescue breaths. She's now wrapping her fingers around the back of the baby and putting her thumbs in the center of the sternum, and 15 compressions. Back to 2 rescue breaths. So for the baby, we've got 2 changes here. We've got 2 to 15 instead of 2 to 30. So we're moving to those breaths a little bit quicker each time. And we've moved from the 2 fingers to the encircling technique. I just want to emphasize though here again, if you were to use 2 fingers, because that's what you've been taught, that's what you're comfortable with, and you are effectively moving the chest and depressing it that third of its depth, then you will still be effective. Or if for some reason you struggle with your thumbs and you go back to your 2 fingers, that's also fine. What we're saying and what the Resus Council is saying is that the evidence is suggesting the thumb technique for most people is slightly, and the difference is not huge, doesn't mean the other one is ineffective, it just means this one is slightly more effective. And so now we will be teaching people the encircling and the thumbs technique. So next change for children and babies, not a big change here. So we're just going to look at the first 2 pictures first. So ignore the adolescent for me for a moment. So for babies and children, you will have been taught, in fact, you will have been taught not to put paddles on a baby. You will have probably been taught only to use paddles over the age of 1, or pads. And your pads were always put centrally on the chest and 1 on the back. So the first thing that's changed here is should be able to see that quite clearly in both of those pictures. Rather than being completely central, what we're being asked to do now is move the pad slightly to the left. So you've got about a third of the pad over on the right side of the chest and 2/3 on the left side of the chest. If you're using children's size paddles, that should work the same on a baby. If you're, and I'll talk about adult paddles in a second, but if you were having to use large paddles on a baby, you might just end up with it taking up most of their chest. Again, that's not a problem. So you have been told in the past that if you do not have a defibrillator that has the ability to adjust to a child, so have the smaller settings or the small pads, and definitely for a baby, that you shouldn't use it. Now, this is another quite big change in now what you are being told is if the only thing you have got is adult pads, then you are still going to use adult pads on a child or even a baby. And I'm going to explain this in a second so it doesn't sound quite so scary. And the other thing we're going to say, that the other change is that no longer do we distinguish under one. We are going to put automated defibrillator pads on everybody who is in cardiac arrest if you have access to an AED. Now, probably most of you have remembered when you did your courses that the defibrillator bit is actually quite scary for most people because we know that you're giving an electric shock. It feels very intense. It feels very medical. But what hopefully you do all remember from the last training you did is that people would remind you that this is not something you are deciding. It's an automated machine and it's going to read the electrical activity within the heart and it's going to decide whether your patient, so your collapsed person, has a cardiac rhythm or cardiac activity that would be appropriate to shock or if they don't. Now, the really important thing to emphasize here is that always you should have been taught that it's incredibly unusual for a child or an infant to collapse due to a problem that would be fixed by an electric shock, so fixed by the use of a defibrillator. So if you put the defibrillator on a child and they don't need to be shocked, the machine is just going to say to you, shock not advised, continue with CPR. Or continue with compressions, usually is what it says. So it wants you just to get back into your doctor's ABC. Now, what the argument currently is that if you had a child in cardiac arrest or a baby in cardiac arrest who was in this very, very rare circumstance where they were in a shockable rhythm, CPR alone is not going to be enough for them. And it's really, really important they have that shock and they have that shock early. It is better that they have a shock that is of a higher joule than ideal than to not be shocked at all. I'm hoping I've explained that clearly enough. So really what it's saying is that everybody now has the pads put on. Sorry, I keep saying paddles, I'm too old school. The pads put on their body and to allow the machine to read their electrical activity. And at that point, the machine will decide if a shock is required. As I said, for most children, it won't be. But if it is required, it is better that you have a higher dose shock than no shock at all. Now, because our young people over the age of 12, so we're looking at our adolescent picture here, the third one on the right, over the age of 12, our chest is much bigger. We do the front and back purely because of the physical size of the chest. Once we become an adolescent, or an adult, but we're not doing really adult today, you will recall that you've always been taught to put one pad on just sort of on the right side of the chest, just underneath the clavicle, and you've generally been taught to put the second pad just under the left breast. The emphasis here now is that one of the pieces of research has suggested that this pad position runs the risk, especially if it's quite far round on the chest, of missing, or not really missing, but skimming across the top of the heart with the electrical impulse. We really want that electric shock to go right through the middle of where the heart is. So that pad that normally sits just under the left breast, the emphasis is really to put that right under the armpit, right under the axilla. So we're going to have one pad in the same place as it always was on the right side of the chest, but just move that pad, if you're doing it on a bigger person, so you're over 12, under the left armpit. Again, these slides are available to you, and I think Tina will talk about it at the end, but there is some shortened e-learning if anyone does want to just have an update. So that's our changes for CPR. We're just going to very quickly look at our changes for choking. You'll be pleased to know these have not changed very much at all. So there is back still that emphasis, which has only really been around for the last few years, on actually trying to encourage someone who's only mildly choking to cough themselves, because that is a very good mechanism for enabling things to move, and we should only be intervening if someone can't really cough for themselves. So there's that first bit. But actually, if someone's severely choking, they can't respond to you, they can't cough, they can't talk, and they're probably not making very much noise, they're looking flushed, they're looking pale, then you're going to move to your choking manoeuvres, but also really consider calling for help early. So this hasn't changed. I'm going to very quickly, just a quick reminder. So your choking algorithm for a child, first to encourage the child to cough if they can, get some help. If they're not able to cough effectively, while someone else is calling for help, you are going to give 5 back blows. Again, I'm not explaining this because everyone should have done these before. These haven't changed recently. So 5 firm blows on the back, so between the scapula, so over the sort of between the shoulder blades, and then 5 abdominal thrusts. So with children and adults, we use that motion inwards and upwards on our stomachs, exactly as shown here. So but one of the things that is being reminded and really emphasized, again, this isn't new, you are only doing this whilst a child is still responsive. So they may not be able to cough, but they are still conscious. At the point at which your child becomes unresponsive, you then move to CPR, and you follow the CPR algorithm, not the choking algorithm anymore. Infants who are choking, only real thing that's changed here is in exactly the same way as with our chest compressions. You've moved from the 2 fingers on the chest thrust. So we will do the run through the algorithm in 2 seconds again, but you used to move your fingers, use your 2 fingers to push on the chest for a baby, because we don't want to be pushing over their stomachs or over their abdomen. Now you're going to do exactly the same movement, but you're using the 2 fingers, and there is a video of this bit. So probably best to rest them on, whether you're sitting, leaning on something, on a chair, or kneeling on the floor. Rest their back so you've got pressure either side, and you're now going to use the 2 thumbs to do your chest thrusts. So for our infant, the cycle hasn't changed at all. It's 5 back blows and 5 chest, not abdominal thrusts. There's, as I said, video just coming, but using your thumbs instead. And again, that emphasis on if they become unresponsive, you must move to your CPR algorithm. So let's just quickly play that one. So what will have happened first is 5 back blows. So the baby would have been over on their front and had 5 back slaps first. And then when we move to chest thrust in a baby, it's using the 2 thumb technique. Okay, very, very quick, not one. This hasn't changed, so just something to remind you, but it is just really, really important that should you have done abdominal thrusts, I would probably argue if you've moved to chest thrust 2 on an infant, so someone under the age of 1, then they really should have some a medical review afterwards. So if you've just needed to give someone 1, 2, a couple of back slaps and the object has flown out, then there's no real need for medical attention unless you are worried or concerned. You're very welcome to, but there's no requirement. But if you've done abdominal or chest thrusts, then that person, 1, didn't have oxygen entering their body for a period of time, but also they are both quite traumatic and physical maneuvers. So you may well have created an injury that is appropriate, we can treat from, but actually should be seen. If they have difficulty swallowing after, swallowing probably means that the object isn't actually in the trachea, it's probably stuck in the esophagus, but we want them to still be checked and make sure we haven't got airway trauma. If there's a persistent cough, so if after the object's come out, the child is still irritable and coughing, then they need to be seen medically, or they're stating that they feel like something is stuck. So I'm going to move back to Tina for the moment. So thank you for that. And Tina's just going to chat you through the choking devices.
Hi there. Thank you for that, Amy. So there is not really much of a change in terms of what the Resuscitation Council is recommending. So they've changed the wording slightly, but they are still saying that there's not enough evidence for them to make a recommendation for or against, which doesn't, I know that's not the answer that lots of you want. And I know that lots of you are bombarded on social media with ads about these choking devices. And I would really urge you to swipe past those ads because they're there to make money. And the data that they, these stories that they tell you, we have no way of checking whether that is real evidence or not. The place that those choking devices have definitely had some really good feedback is in places like care homes, where you've got patients who are not mobile, who are maybe in bed, who are in sitting positions, but where you can't move them, and where it's very hard to follow the standard choking protocol of back blows and chest thrusts. And then that device, there's definitely evidence that has been very useful. In a pediatric setting, there just isn't enough evidence to say, yes, you should definitely have one of these. If you have got one, and you've been given training on how to use it, that's fine. But the guidance is that you follow the standard choking practice algorithm first. So you do your back blows, you do your chest thrusts, your abdominal thrusts, depending on the age. And then as a last resort, you've got that device, you can use that device, but you must follow the standard protocol first. Apart from anything, you don't want to be running off looking for the device, putting it together, because you're losing really valuable time when back blows may well have dislodged the object first go, which is quite often the case. If you have got one, as I just said, make sure that you're trained, that all your staff are trained. Sorry, Amy,
That was
uh,
my fault, sorry.
yeah, all your staff are trained in using it, and make sure that you have it covered by your written risk assessment policy in line with the EYFS safeguarding and welfare requirements. And if you're using it, make sure that you record its use and you report it. I think that there's a yellow card reporting system for it. So Amy, if you go on to the next slide, thank you. Yes, so just as a warning, there was a recall about cheap counterfeit products failing to work correctly, which actually could make the situation worse. So if you are going to get one, make sure that you don't just go onto Amazon and buy one. You need to make sure that you buy one from a trusted distributor. We will send details of that to you in an email after the webinar of the UK distributor for the LifeVac device. But I urge you really, really strongly, please don't see it on social media and think, wow, we've got to have one of those, because those ads are there to sell. And thank you so much for giving us your time, and we hope to see you on another webinar soon.